So treating UTIs made uncomplicated. This is a case-based discussion, and first case is 24-year-old newly married female presented with low abdominal pain, dysuria, frequency for 3 days duration. There was no fever or chills, no vomiting, back pain or general ill health. Blood pressure was 110/70, so patient was hemodynamically stable. There was no suprapubic tenderness. There was no signs of peritonitis, and patient does not have any past medical history or previous history of UTI. So remember to ask those things as Lakmal mentioned. She was presented to the OPD and managed with empirical antibiotics. The question is, what is your choice of empirical antibiotics? Is it IV coamoxiclav? Is it oral cefalexin? Is it oral cefalexin plus oral ciprofloxacin, oral nitrofurantoin, or oral cotrimazole? What would you think? The answer is oral nitrofurantoin and oral cotrimazole. Right. So before that, as Lakmal said, right, make sure that you choose the appropriate antibiotic for appropriate situation. This is a patient with an uncomplicated cystitis. So appropriate antibiotic in this situation would be nitrofurantoin or cotrimazole. But how many patients do we see in each and every day are on these antibiotics for simple cystitis? And these patients will be on ciprofloxacin, coamoxiclav, and many sophisticated antibiotics as well. Remember, as Lakmal said, so you'll be treating your patients with these sophisticated antibiotics, and next time your relatives, your family member will come up with an resistant urinary tract infection. Right. So next question, does this patient need an culture? Does this patient need an ultrasound scan abdomen? Does this patient need an ultrasound scan of KUB? These simple cystitis patients who are uncomplicated, they don't need further investigations. And the evidence shows treatment with uncomplicated cystitis does not need any further urine cultures or ultrasound scan abdomen, because that does not increase the diagnostic yield or the patient outcome. Similarly, when you treat the patient with that antibiotics, if the patient is asymptomatic, you don't need further urine cultures or scans to follow up. We have seen many patients who are asked to come in 1 week time for a scan or a repeat urine culture. That does not need. If you want to send the culture, send if the patient has had recurrent UTI, if the patient is a pregnant female, non-relevant anatomic or functional abnormalities in the urinary tract, or uncontrolled comorbidities such as diabetes. And of course, if you suspect in the history whether there's an obstruction or disturbance to urinary function, maybe urinary incontinence, maybe reflux, then do a ultrasonic scan of the KUB. Right. So why we don't use nitrofurantoin and cotrimazole? Some facts regarding nitrofurantoin and cotrimazole. So we are a country where ESBL is much prevalent. It's local studies suggest about 20 to 30% of ESBL prevalence in this country. Nitrofurantoin and cotrimazole both has good ESBL cover. Not cefalexin, not coamoxiclav. So if use nitrofurantoin, but be aware of, avoid if the GFR is less than 45, GI side effects are low related, and serious reactions are very, very rare. Cotrimazole similarly, avoid in renal impairment patients and elderly, educate about the rash or mouth ulcers, and to stop the drug if they appear. SJ is very, very rare and 1 in million. I know most of you guys will hesitate to prescribe cotrimazole because the patient will get SJS. and duration in 3 days in females, 5 days in males. So this is the guideline published by the Sri Lanka College of Microbiologists. So acute uncomplicated cystitis, so treatment is as suggested. Right. Let's move on to the case scenario 2. Now we have a different patient, 45-year-old patient with a male patient presented with 3 days history of fever with chills and right-sided abdominal pain. He is diagnosed to patient with diabetes for 5 years with retinopathy and nephropathy. He had nausea and vomiting, and his hemodynamics are unsettling. BP 90/60, pulse rate is 100, CRFT less than 3, and he has a high temperature, and his blood lactate level is 2.5. So, patient is having pyelonephritis with septic shock. What is the empirical antibiotic of choice? Is it coamesclove and ciprofloxacin, IV coamesclove and IV ciprofloxacin, IV coamesclove and IV gentamicin, IV piperacillin tazobactam or IV gentamicin, and IV gentamicin? The answer is IV piperacillin tazobactam and IV gentamicin. Before describing why that we made that choice, I will just furnish your brain what Lagma said earlier. Before offering an antibiotic in this complicated situation, think of the severity of the symptoms of the patient. As the patient presents to you, it may be AOPD, it may be ETU, it may be in the ward. See the patient's severity of the symptoms and see that the patient is having high risk of complication, such as diabetes, such as uncontrolled other comorbidities, whether the patient has previous urinary tract infection with culture positive and whether there's ABST results are available, and whether the patient has been given a course of oral antibiotic, because that will suggest to you that the patient is again in high risk and you will have to optimize and escalate the antibiotic treatment. Right? Of course, in this patient, as you come to the management, patient is in septic shock, so you will have to come to the sepsis criteria. You will have to give IV fluid, you have to give oxygen, you have to measure the urine output. Start with empirical broad spectrum antibiotics and start resuscitating the patient. So this is a complicated pyelonephritis. Where do you make this difference? Uncomplicated pyelonephritis from complicated pyelonephritis. Uncomplicated pyelonephritis is defined as pyelonephritis limited to non-pregnant, premenopausal women with non-wound relevant urological abnormalities or comorbidities. And it typically does not show signs of sepsis. Right. So if it is uncomplicated, not in this case like complicated, what would be the antibiotics of choice? Right. So the guideline says it is either coamesclove or coamesclove and gentamicin, depending on the severity of the symptoms of the patient. Right. So when do you suspect complicated urinary tract infection? Check whether there is a history of obstruction at any site of the urinary tract, foreign body, incomplete voiding, vesicoureteral reflux, recent history of instrumentation, ESBL producing organisms isolated in a previous history or recent history, male urinary tract infection, pregnancy, diabetes, immunosuppression, so and so on. Right, guidance on escalations. Now we have got a complicated pyelonephritis, so how do we escalate the antibiotics? Especially in urosepsis and septic shock, choices would be piperacillin tazobactam and gentamicin. If bacteremia present, of course, meropenem and gentamicin is preferred, that is the Merino trial, right? And always check whether the patient is having risk factors of ESBL infection. Age, multiple comorbidities, recurrent urinary tract infection, intensive care stay in the recent or past, previous care of use of antibiotics such as cephalosporins or colonization with ESBL. Right. So if the patient is, what the guideline says, complicated pyelonephritis, so you can go for either cholesterol or gentamicin. If the patient is having urosepsis, it is ceftriaxone, gentamicin, or you have to switch on to piperacillin tazobactam plus gentamicin if the patient is in urosepsis or septic shock. Right. I would like to say a few words about gentamicin usage in pyelonephritis, because that is a drug which we don't use much, but it has a very good efficacy. It has concentration-dependent killing and known to achieve high peak concentration to kill the bacteria. And once daily dosage is satisfactory, because even at trough levels, it kills bacteria and the antibiotic effect remains. Serum creatinine and EGFR daily should be done, and dose needs to be calculated according to the body weight, but maximum dose should be 480. And if normal renal functions, I need to highlight this point, if normal renal function, you can use 1 or 2 doses without checking trough levels. I know most of the hospital, they cannot check the trough levels, but you can use 1 or 2 doses. And remember, if you exceed more than 10 days only, you will get these gentamicin side effects, ototoxicity and these things. But maybe more than 72 hours you might even get, but usually in longer courses only you will get these side effects. Right? So once you start the antibiotics, remember, as Lakma said, you need to reassess the patient, whether the patient's symptoms worsens or improve. If it is not to improve in 48 hours, you will have to think of other diagnoses, other serious offense. So search for the source and treat the source, and whether you are dealing with a resistant bacteria. Right? So case scenario continued. So this patient culture came as ESBL E. coli positive and resistant to coamociclovir, sensitive to Cotrim and ciprofloxacin. Now this patient is in 3rd to 4th day, patient is improving. So you need to de-escalate, as Lakma says. So make sure that when you are switching the oral to IV to oral antibiotics, check the sensitivity and switch appropriately. So oral Cotrim or Cipro, but nitrofurantoin is not recommended for pyelonephritis. Duration, yes, 7 days is enough. So IV plus oral total 7 days is enough. And as previous speaker said, make sure that you do the source control as early as possible. Thank you.